Here we go. How do you do? This is Dr. Bernstein with our February 2019 teleseminar. Before we begin, I want to give you the usual warning that my answers to your questions are generic answers. They're not necessarily focused on your particular problem because I haven't done a physical exam on you. I haven't gotten your complete medical history, family history, etc. So it's frequently impossible to give an appropriate answer. But the answer I give, hopefully, will be educational to all the listeners and give you more information about the physiology of diabetes and the treatment of diabetes. We have a special subject this time round. It is an update on glucophage. As you know, in my experience, there have been variations in the product metformin, which is probably the #1 recommended oral agent for type 2 diabetes. I also use it a lot for type 1 diabetes for people who have arbitrary blood sugar fluctuations, such as in growing kids, sometimes in women as a result of menstrual cycles, and frequently metformin will level out blood sugars for type 1 diabetics, but it's primarily used for type 2 diabetes. And what we found years ago was that the brand name glucophage was much more potent than the generic versions. Whether that is still the case today, I don't know. This happened like 15 years ago, but I've been, wherever possible, prescribing glucophage as opposed to generic metformin. As you may know, glucophage was recently went off patent and was discontinued by its manufacturer, Bristol Myers, which sold the rights to another company. And of late, most patients have been unable to get it in the USA. There may be some supply remaining with some distributors, so occasionally you can get some, but officially it's not being distributed in the USA by the manufacturer. The new manufacturer is an American company called Serono, S-E-R-O-N-O, Pharmaceutical, and you might be interested in getting their phone number, which I'll give to you in a minute. They're trying to decide whether they're going to market it in the USA. As you know, there are certain stringent requirements of the FDA that may require testing, a costly testing and so on. So there may be reasons to discourage the actual manufacturer from selling it here. But we want to encourage them, of course. The product, glucophage and glucophage XR, is being distributed in Canada. So if you have contact with Canadian pharmacies, you might be able to procure it. The problem is that it's quite likely that your USA insurance company is not going to pay for products imported from Canada. There are new laws pending before Congress that might permit the importation of pharmaceuticals, and these might change the picture for insurers, but right now it's not likely to be covered by U.S. insurers. Now, if you want to get after the manufacturer to encourage them to distribute in the USA, I'm going to give you their phone number. So if they feel overwhelmed, they might become interested. The number is 800-283-8088. 800 283-8088. And that's Serrano, S-E-R-O-N-O, Pharmaceutical Company. Now we'll go down to our questions. The first one, taking glycomet, which is a form of metformin, 500 milligrams slow release 3 times a day. I'm on a low-carb diet, and yet my reading is 200 fasting and 373 after meals. Is there any food item which is proven to help lower my reading? Well, first of all, I recommend that you read my book, Diabetes Solution, and you'll see that there's no magic from foods. Avoiding carbohydrate makes a big difference, but you're doing that already. So what can you do to lower your blood sugars after meals? There are certain oral medications for type 2 diabetics that might be more potent than metformin, may also have potential for more adverse effects. And there's insulin, which always works. So you can talk to your physician and see if he's interested in prescribing insulin. And if he does, he should follow the routine that's in my book, Diabetes Solution, because just the arbitrary use of insulin without having a logic behind it can lead to trouble. Are gallbladder issues common amongst diabetics? And do you feel that your eating plan could reverse or at least improve my gallbladder function? It's interesting. I have not seen many gallbladder problems amongst my patients, but when I was in medical school, we were taught that gallbladder disease, both stones and infections, especially infections, are common amongst diabetics, more so in diabetic women. Now, and we were advised back then that if a female or anybody gets one gallbladder attack that is with a fever sign of infection, that without waiting for an emergency, they have the gallbladder removed because an emergency cholecystectomy or removal of the gallbladder is much riskier than a planned removal, an optional removal. So now, as far as our diet goes, a low carbohydrate diet per se doesn't help or hinder gallbladder symptoms, but if you're using a lot of fat, the gallbladder secretes bile, which helps break down fat. That's one of its primary functions, and it will be busy producing more bile if you eat a lot of fat. So if you have gallstones, they're more likely to be stuck in the outflow duct of the gallbladder if you're eating a lot of fat. So the tendency of many people to inappropriately add fat to a low carbohydrate diet certainly is not supported by the experience of people with gallbladder disease or stones. With your low-carb diet, my 1 and 2 hours postprandial blood glucose is always below 120 milligrams per deciliter, but I'm disappointed that my A1C is still 5.7%, which would suggest an average blood sugar of about 128 milligrams per deciliter. My endocrinologist says I technically don't have diabetes, don't need to be on any medications since my A1C has now normalized. Well, should I change doctors and ask for glucophage XR? First of all, an A1C of 5.7% by my standards is not normal. It's an average blood sugar of 128. Studies have shown in general populations, non-diabetic populations, that the lowest mortality is an A1C of something under 5. I think it's 4.2 to 4.6. Actually, an average blood sugar of 83 seems to have the lowest mortality. And here you're talking about 128, which is more than 50% higher than 83. So I certainly can't consider that a normal blood sugar. Yes, it's in the range that the American Diabetes Association calls normal, but as you can see on my videos, the reasons for calling a high blood sugar normal have nothing to do with the well-being of patients. It's more oriented to the needs of physicians. So maybe glucophage XR or whatever the equivalent that's currently available would be of value. Certainly, I wouldn't be happy with an A1C of 5.7. It's interesting, the manufacturer Eli Lilly recently, maybe just this week, has a new advertisement that says, for type 2 diabetes, if your A1C is over 9%, consider insulin. And to me, if it's under 9%, what's the doctor supposed to do? Watch the patients slowly develop all the complications of diabetes? I have sitosterolemia, which is a disease where vegetable fats cause very high triglyceride and total cholesterol levels. And it's considered a cardiac hazard to have such high levels, I would say, certainly of the triglyceride. Now I am on ezetimibe, which is a drug that lowers cholesterol. My dilemma: I don't really need to lose much weight, but I have tried to intake fat to make up for calories lost by reducing carbohydrate. Now I have no idea what to eat, because this person is thinking about vegetable fat as the only fat to consume, which of course isn't the case. I have tried to intake fat to make up for calories lost by reducing carbohydrate. Now I have no idea what to eat. Vegetable fats are out, whether innocently disguised as avocado or an olive, and I can't fry my fish in anything. Why can't you fry your fish in butter? This is the common prejudice that's out there, especially amongst physicians, that animal fats are harmful. How do I keep my weight up? Well, first of all, silosterolemia is not causing problems with animal fats. So animal fats are okay. You could use butter for cooking. There are other ways of cooking that don't involve frying. You don't have to fry. As far as maintaining your weight, you can eat more protein, and if that increases your blood sugar, you could ask your doctor to consider insulin, because a combination of insulin and protein is what I use for most of my patients if I want them to gain weight. I don't use high carbohydrate and insulin, which is, again, a nice combination for gaining weight, but it's a great way to screw up blood sugars. And as I warned before, if you're going to be, if your doctor wants to try insulin, he should read my book, Diabetes Solution, because you can't just put a patient on insulin. It's not that simple. It's a complicated process, and we go into it in detail in the book. I had proliferative retinopathy, but following your guidance in the book, the development of morbidity was reduced. What does he mean by morbidity? Maybe his vision is improved. 2 years ago, I stopped weightlifting. My question, can I go back to weightlifting, and can I reverse diabetic retinopathy completely? Okay. First of all, there are many forms of retinopathy. There's mild retinopathy, there's proliferative retinopathy, there's macular edema, there are several forms of macular edema, et cetera, et cetera. So I would suggest that you ask your retinologist if you could continue or go back to weightlifting. Weightlifting can increase intraocular pressure, and for certain forms of retinopathy, that can cause a bleed. But for other forms, it may not cause any problems. So speak to your retinologist, and you might want to find out what type of retinopathy you have. I'm a type 1 diabetic with an insulin pump. I have been on metformin, Jardiance, that's a DPP4 agonist, and Victoza for a year. Now my A1C and weight loss has dropped significantly. No, my A1C and weight has dropped significantly. What are your thoughts on type 1 diabetics being on type 2 medication? Well, it is possible for certain medication like metformin to facilitate weight loss because it may reduce intestinal absorption of carbohydrate. Note that I said may. And it also lowers insulin resistance, so it can be of value. The fact that you're on an insulin pump suggests to me that you probably have, and even though your A1C has dropped, it probably is not normal, because I've never seen a type 1 diabetic with normal blood sugars on an insulin pump. I think I once saw the case where it was a newly diagnosed patient who was making substantial amounts of his own insulin. So the amount of insulin he was receiving from the pump was very small, and he was able to maintain pretty normal blood sugars for about a year, and then, of course, things went haywire, as they usually do with insulin pumps. So I would think that an important idea would be to get off the insulin pump, read the book, Diabetes Solution, for how to switch to injected insulin. I'm having great difficulty finding a doctor who will perform the autonomic neuropathy tests to test if my daughter's gastroparesis is being caused by damage to her vagus nerve. Well, first of all, if she really has gastroparesis, the chance, and she's a type 1 diabetic, the chances are overwhelming that it was caused by damage to the vagus nerve. But do you know that you know for certain that she has gastroparesis? Well, we have a chapter on gastroparesis in my book. It is possible by looking at a lot of blood sugars taken frequently over many days to figure out, just by looking at blood sugars, that you have gastroparesis. And we, in the book, give you the guidelines for doing that sort of detective work. As far as finding a doctor who does the RR interval study, which is what you're talking about, it's pretty hard in the USA and probably also overseas. It's used as a research test, not routinely in the treatment of diabetics. However, there are diabetes centers for treating diabetes scattered around the country, where they also do research on autonomic neuropathy. So the Joslin Diabetes Center certainly has people who know how to do an RR study. There's another diabetes center in Minnesota that knows how to do RR studies because they're doing research on autonomic neuropathy. So it is possible to find people. There are some alternative doctors who are trying to sell products or magical services and are using the RR study as a come-on. You might be able to get them to do an RR study even though you don't purchase their products. I've been campaigning for a long time to try to get doctors to do the study. The trouble is that it takes time, and doctors don't have time. A nurse practitioner or even a nurse can do the study if she knows how. We have a protocol published in the journal Diabetes Care that I submitted many years ago. So if you look under mine, I'm having some trouble switching from Lantus to Tresiba. These are basal insulins. Any suggestions? Well, whether you're taking Lantus or Tresiba, I usually prescribe it twice daily, once on arising in the morning and once at bedtime. Usually the two doses are equal. However, with type 2 diabetics, sometimes they only get it in the morning, sometimes they only get it at night because they may not need 24 hours of basal insulin. They may be making enough of their own. For type 1 diabetics, we have a protocol for starting any basal insulin, and it would apply here. We would probably take your total dose of Lantus, if you're type 1, split it into 2 shots, one on arising in the morning, one at bedtime. Now, I would initially lower the dose by about 20%, lower the dose of each shot by 20%, just in case it's more effective than the Lantus. We don't want to give you hypoglycemia either during the day or overnight. You may find, however, that you have to gradually increase it to match the prior Lantus dose. Not guaranteed. Have reports of people who require much less insulin with the Tresiba. So you have to be careful and not overdose. Initially go on lower than you would expect. Down the road, many type 1s, because of the dawn phenomenon, will need their second shot or the first shot, not on arising in the morning, but 3 hours before they get up in the morning. So that's a real possibility. And in my case, I take it 4 hours before my usual time for waking up. So I have to set an alarm for 4 a.m. and get my Tresiba shot then. So I take it at bedtime and again at 4 a.m. In effect, I'm getting an overlap of the two shots at the hours when the dawn phenomenon predominates. I'm a type 1 for over 40 years. Well, this person is a survivor. I would also, by the way, just seeing that, say he probably has gastroparesis because those 40 years have not been normal blood sugars. I'm sure he did not read my book 40 years ago. So type 1 of over 40 years and follow your diabetes solution diet. I have found that regular insulin outlasts my protein meals, even if I take it an hour before eating. What do you think about taking a fast-acting insulin just after meals instead? Well, first of all, it could be that your stomach is emptying more rapidly than your insulin works, which would be the opposite of gastroparesis. But with 40 years of type 1 diabetes, I would suspect that you have gastroparesis and that there's something strange about your experience. Taking a fast-acting insulin after the meal may well work. In fact, by fast-acting, I mean regular insulin, not a faster insulin. I have many people with gastroparesis who do not take their insulin before the meal. Rather, they take it in the middle of the meal, at the end of the meal, even an hour after the meal, because the food is just sitting in their stomach, not going out. So that's a real possibility. We even, in the book, recommend adding a little bit of NPH insulin to the regular insulin to slow it down. So it looks like you may need a slower insulin, not a faster insulin, and you should probably take it after the meal. But I don't know for sure the status of your gastroparesis, and our study would certainly help. I find that I'm only able to follow your regimen when my workload is low. Now that I'm working 12 to 14-hour days, my diabetes gets little attention and I'm back on the roller coaster. I'm considering giving up on this job due to the large responsibility and pressure involved, because I have no mental energy or capacity left to make appropriate decisions and take the necessary actions required for stable blood sugars. Do you have any insights to offer? That's a very good question. I think that it probably would be wise to evaluate your options. What's more important, this particular job or being a long-term survivor? I had one patient who worked in a hospital with varying hours and long hours, and could not devote adequate time to treating his diabetes. And he was the only patient who had a heart attack after I started treating him. He really could not be taking care of his diabetes and had widely fluctuating blood sugars just because he didn't devote the time. So you have to decide what's more important. Hopefully you could find another job. I got my C-peptide result, and it's 0.97. Normal level bottom is 0.8. Does that mean I don't produce enough insulin to cover a low-carb diet? Is 0.97 enough to need added insulin injections? First of all, I've said this in prior videos, that the C-peptide test is meaningless if you don't know your blood sugar at the same time. If you have a blood sugar of 300 and a C-peptide level near the bottom of normal, you could be sure that your response to blood sugar by your pancreas is almost but not quite nil. On the other hand, if your blood sugar is 50 and you show C-peptide near the bottom of normal, you would expect that. You'd expect it to be 0 if you had a blood sugar of 50, which would be indicating that you're not making insulin at that moment. So an arbitrary C-peptide all by itself has no meaning. 5-year-old daughter with type 1 diabetes. I was thinking to mix long-acting Lantus insulin and regular insulin, Act Rapid, for the nighttime. Is there any problem with this method to avoid the additional 4th injection per day? If there is, please tell me. Well, first of all, if you've been listening to my teleseminars or seeing my videos, you know that I don't recommend Lantus insulin. There's still a controversy over whether it causes a higher incidence of cancer. Secondly, you know that Tresiba is a longer acting insulin and therefore would be more appropriate. Thirdly, there's no evidence that you can mix regular insulin with Lantus insulin. I don't think it's ever been tried, and I don't know what the purpose would be, because you want the insulin to last longer, not shorter. On top of that, avoiding a shot in a child is almost without any reason. I have heard people using the ADA methods of giving slow injections and in inappropriate sites. And I actually heard videos of the child screaming when given that way. But it's possible to give a totally painless injection, as we explain in my book. Why do you want to avoid injections? Not only that, if you're giving the patient the right dose of insulin, not the high doses that are usually recommended, it's a tiny shot and it's over in less than a second. There's no reason to avoid doing this. I've heard you suggest glucophage may be better than generic metformin. I've purchased a 6-month supply of glucophage and plan to check my A1C at the end of the period. Comparing it to my beginning value of 5.5 on the generic drug, does this seem like a reasonable plan? Would you do anything else to check any other laboratory values? Well, you want to see if your blood sugars are consistent. So I would think that you'd want to look at a few weeks of blood sugars, save the data, collect it the way we advise you to collect it in the book using our forms, and you could compare your blood sugars before and after, not just the A1C, because you could have a wide range of blood sugars and the same A1C as a smaller range that has a little higher average. So the A1C by itself is not going to give you the whole answer. I have type 2 diabetes. I drink 4 to 5 gallons of water a day. However, my urine is still dark brown. I can't drink more water and my tongue is always dry. What can I do? Well, there are a number of diseases that can cause brown urine. And there's also at least one very important disease that causes extreme thirst and frequent peeing. So if you have diabetes and the blood sugars are very high, you can be forced to drink all day long. 4 to 5 gallons is like 4 times as much as most people drink. Most people drink 4 to 5 quarts. This is a huge amount of water and is not particularly healthy. I suggest that you contact probably a hematologist initially, because there could be some form of blood disorder that's causing this. You may also require a nephrologist, a kidney doctor, or even a hepatologist, a liver doctor. My guess is you start with the hematologist and take it from there. But this certainly is not normal and sounds like something serious. What is your opinion of the 90-second microwave keto bread? Well, first of all, why do I recommend any carbohydrates in a diet for diabetics? Because I think that it's necessary to have vegetables in your meal plan. And I recommend that the carbohydrate that you add be vegetables. The total amount of carbohydrate is pretty low, so it's not like we're overloading people with vegetables. And to find a treat like bread instead of vegetables doesn't make sense to me. So I don't think it's a good idea to purchase a substitute for bread or a substitute for candy or other sweets from any source. I could be wrong about this source. Maybe it's all made from vegetables, but I can't, it's hard for me to imagine that you're making bread out of a mixture of vegetables. Type 1 since 1977. So this is another survivor. A1C is 4.5. And any suggestions on how to investigate why my total cholesterol is so high, which is 404. I'm active, energetic, and lean. I know you mentioned that weight loss causes a temporary elevated cholesterol. I never said that, I said triglyceride. But 404 seems extreme, and my weight has been stable for a couple of months. Well, first of all, um, total cholesterol is not really a risk factor for heart disease. That's been shown in recent scientific studies. There are many tests that you could take, blood tests, that are good measures, and perhaps most important would be an imaging test, the coronary artery calcium score. The most potent of the tests that I've seen is the LP small a in females, where every person, well, actually in anybody, every person who's come to me for the first visit as a new patient who's already had a heart attack, each one of them had elevated LP small a. So to me, that's a very good predictor. And they did not have high total cholesterol. There are other cardiac risk factors like oxidized LDL, small dense LDL, C-reactive protein, D-dimer, fibrinogen, triglyceride. This person's triglycerides were quite reasonable, 108. HDL was 64. Now, the total cholesterol includes triglyceride and HDL. Some people take a fifth of the triglyceride and subtract it from the total. Some subtract all of the triglyceride. So if we took the 64 and the 108, that's 172. That brings the balance of cholesterol to something like 225. It would be interesting to see what the LP small a is, but don't look at total cholesterol. Look at all these other factors and get a coronary artery calcium score. Talk to your doctor about these things. If you have been diagnosed with prediabetes and have lost weight and continue to lose weight, what can you do to gain weight? I am down to 89 pounds and this is affecting my bones. I have not been given any medication or insulin. A1C is 5.5. Well, as I've said before, the most common thing that I do to have patients gain weight is to increase their dietary protein, and if their blood sugars go up, to cover it with insulin, because insulin helps build, is an anabolic hormone that helps build muscle and also fat. In the case of eating the protein, you're more likely to build muscle. I am 59 years old, male, diagnosed as type 1.5 diabetic 4 years ago. Now, there is no definition that I know of for 1.5 diabetic, but I've seen endocrinologists diagnose people as 1.5 for a host of reasons. My guess is that this person needs a tiny amount of injected insulin, but I'm not sure. I inject 9 units of Tresiba and about 6 units of Fiasp, which is the new Novolog, per day. My diabetic educators say after a month I should throw the insulin pens away and start with new pens of Tresiba and Fiasp. Is that true, or can I keep using the insulin pen until all the insulin is used up? Well, first of all, the Tresiba comes in a box with 5 cartridges, each of which holds 300 units. And if you're getting 9 units of Tresiba a day, and you're changing needles periodically, you have to inject at least 2 units to fill the needle. So let's say that that took you to 11 units, but if you don't change the needle every day, let's say 10 units a day, the 300 units in a cartridge will last 30 days. And so you're worried about what if the cartridge lasts more than a month? It's not going to last more than a month. In fact, you're probably going to use it up in a little under a month. So I don't know why that's a problem. But in response to your question, if you keep the pen and the cartridges in the refrigerator, as I do, it should last for a long, long time. The Fiasp, which is Novolog with some, I believe, niacinamide added to dilate your blood vessels, that likewise, Novolog has a history of lasting a very long time, even out of the refrigerator. So if you keep the Fiasp in the refrigerator, I don't think that's a problem. As usual, many diabetes educators just don't know that much about diabetes. Now, one little point, the manufacturers of both these insulins say discard after 30 days. You can ignore that. That's playing it safe. They don't want to take any chances, so I don't think you have to worry about that. For a new type 2 patient, do you ever start off using insulin? Well, first of all, it depends what you mean by new. If it's newly diagnosed, new to my medical practice, there's a whole spectrum of what you might mean by new. If the patient has, remember, most type 2 diabetics are not diagnosed until they've had it for many years and are now getting symptoms. And by that time, they may well have burned out a lot of beta cells just by having high blood sugars for years. And indeed, I see a spectrum of new patients. Some of them are very mild and may get away with using certain oral agents. And some of them come in with such high blood sugars that I'll put them on insulin immediately. And most of the patients who come in here are already on low-carb diets because we require them to read my book. So they've already put themselves on at least a relatively low-carb diet. So if they have blood sugars over 200 and they're on a low-carb diet, we probably would put them on insulin. Sometimes I'll run into a patient who does not want to take injections, or who thinks that insulin is going to make them a permanent diabetic, where right now they're a reversible diabetic. That's a lot of nonsense. If they're fearful of the insulin, I'll start them off on oral agents, and I'll give them gradually higher doses and a variety of agents, not prescribing any that I know to be harmful, and they might see their blood sugar going down a little, but when they see that we reach a point where it doesn't go down any further and we need insulin, they're usually ready to do the switch. And since some of the products that are sold for type 2 diabetics, like the GLP-1 agonists, are injectables, and there are several different kinds of drugs that are injectable. They already know how to give injections because we've been trying these drugs on them. They don't mind injecting the insulin. If someone is following your dietary guidelines, at what blood glucose level or A1C would you consider that dietary controls have failed and feel insulin is needed? Well, first of all, if we're talking at type 2, I would try weight loss, glucophage or metformin, exercise, and if that doesn't get their blood sugars very close to the target of 83, we'll use insulin. If they're always running, let's say, between 90 and 110, my preference would be to use insulin if we can't get it down any further. But I let them decide. That's a relatively mild increase in blood sugar, and I've managed to slow down the diabetic complications by this degree of reduction. Let them decide if it's worth taking insulin to get them down further. If it were me, I would do anything to prevent the long-term complications of diabetes. Now, if we're an 85-year-old person and his blood sugars are running 90 to 110, I probably wouldn't bother to I wouldn't push him. If it were a person who had a dementia, I certainly wouldn't push the system. What tests can a type 2 diabetic use to determine the degree of damage to beta cells? Well, it's very hard to put a number on it. You could measure the C-peptide level, but it must be at the same time with the blood as a blood sugar, and you probably should measure it hand in hand with a low blood sugar and with a high blood sugar. You could look at blood glucose after meals, especially if they're on a low-carb diet. Does the blood sugar still go up? You can nowadays even measure proinsulin. It's been found that almost all type 1 diabetics still, I think it was something like 92%, are still making proinsulin. It's a small amount, and even if it were a large amount, it's only 10% as potent as real insulin. As proinsulin is the insulin molecule before some amino acids are chopped off. The chopped off amino acids are what are called C-peptide. So we have sort of a U-shaped insulin molecule. C-peptide cuts off one end of the U, and then there is some disulfide bonds connecting these two linear pieces. That's insulin. If you put the C-peptide back, that's proinsulin. And you can measure proinsulin levels, and proinsulin is made by beta cells, so you will have an indicator of how much insulin you're making. You will have an indicator of how much insulin you're making. Is it a good strategy to skip all carbs for breakfast, even after exercising for 1 hour? Well, first of all, I don't recommend morning exercise because of the dawn phenomenon. Most people who exercise in the morning find that they get a blood sugar increase. Since I'm trying to give vegetables to my patients, and not everybody likes vegetables. I try to throw some kind of vegetables in at breakfast. Maybe if they're having eggs, we make an omelet with some chopped up vegetables. I don't want to take away the carbohydrate if it could be vegetables. So there's a question as to what the purpose would be. Now, if you're type 2 diabetic and not injecting insulin, you can't be covering the vegetables with insulin. Maybe your blood sugars would be normal if you had no carbohydrate. But certainly the exercise in the morning doesn't help. Can type 2 diabetes cause hair and nails to stop growing? Well, if the blood sugar is very high, otherwise I don't know of just the name diabetes causing hair and nails to stop growing. We see a lot of diabetics, both type 1 and type 2, who have low free T3, thyroid hormone, and a low thyroid hormone, low free T3 can cause reduction of hair and nail growth. Also, a deficiency of biotin can cause interrupted hair and nail growth. And you can measure serum biotin levels. You can also measure free T3 levels. When I water fasted for 7 days and ate very low carbohydrates, my thyroid gland improved, resulting with my doctor to lower my synthroid meds. Now I'm wondering if my type 2 diabetes is the cause of my hypothyroidism. Well, I'm very surprised that your thyroid improved, especially after only a week. And I wonder what the so-called improvement was, what was being measured. I doubt that the type 2 diabetes caused the hypothyroidism. I've seen many people who have developed hypothyroidism before the onset of type 2 of diabetes, and many who've developed it after the onset of diabetes, where the diabetes came first. Hypothyroidism is an autoimmune disorder. Autoimmune disorders come in clusters. So I think I have something like 5 different autoimmune disorders. I doubt very much that that's a cause of the diabetes. It may just be concurrent. Also, people who both diabetes and hypothyroidism come in families. So you could have inherited the tendency to either or both. Is there video and written materials I can access to understand as a layperson how to adjust my 87 years old mother's insulin where difficult to get doctor to supervise change to low cardio diet? You can look at my book, Diabetes Solution. It goes in great detail on how to do this. So that's what I would recommend. Ketogenic dietitians are telling people that sugar substitutes will raise insulin. I disagree. Could you please advise? Well, here's a rule of thumb. Beware of ketogenic dietitians. There's all kinds of ketogenic diets. There are all kinds of people trying to make money selling ketogenic products, ketogenic foods, and it's really a lot of nonsense. And I've seen a number of people who are sick from whole protein malnutrition, emaciated with big pot bellies. um, uh, Stay away from ketogenic dietitians. Now, there are some people who actually recommend my book and call it and say that I'm recommending a ketogenic diet. I'm not telling people to test their urine for ketones or test their blood for ketones. I think that it's an inappropriate designation of my book. Low carb and renal lithiasis, oxalate, that means calcium oxalate kidney stones. Any tips? So this is a person who's on low carb and has been getting calcium oxalate kidney stones. Now, I started getting calcium oxalate kidney stones at the age of 20. No, I think 22. That was about 17 years before I went on a low-carb diet. So low-carb diet does not cause oxalosis. I would say that you look up the usual guidelines for avoiding oxalate kidney stones. That's avoiding green leafy vegetables like spinach, not taking calcium pills, trying to get the calcium from your diet, certainly not taking significant amounts of vitamin C. That is not, don't take vitamin C pills. Vitamin C gets metabolized to oxalate. Try to avoid regular tea. That gets metabolized to oxalate. Again, look on the internet for oxalate-free diets. There are a number of substances that are commonly used that get metabolized to oxalate, and you want to avoid those. Your doctor might also want to prescribe potassium citrate. You could even have him check your 24-hour citrate and oxalate levels and see how they vary if you take the potassium citrate, and also how they vary if you cut down on these oxalate foods. My child is 9 years old, and a few weeks ago we had discovered he has type 1 diabetes. I'm wondering, how can we reduce carbohydrates in his diet if he needs to eat according to the doctor recommended ratio? Carbohydrate to protein to fat, 60 to 20 to 20. Well, the chances are that you're going to have to search for a kindly pediatrician. Most endocrinologists or pediatric endocrinologists recommend high carbohydrate diets for everybody, and that's part of the reason for the recent over past generation or so increase in obesity and diabetes. You don't want to do this to a little kid, give him the wildly swinging blood sugars that this kind of diet's going to do. I think you also should join Type 1 GRIT, ONE-GRIT, on the internet, and see what other parents are doing with their children. And as I said, you might find a kindly pediatrician, not an endocrinologist, who may even read the book, but at least who will listen to logic and who will prescribe the things that you want him to prescribe after reading the book. 28-year-old with uncontrolled diabetes for years. Charcot foot on both feet. Charcot foot is really a smashed up foot where because of diminished bone density due to high blood sugars and frequent urination of water-soluble nutrients, the bone density is down, plus they have neuropathy in their feet. They can't feel their feet, and whenever they take a step, they're smashing their foot against the ground and not knowing it. So they smash their foot until it resembles a bag of broken bones. That's Charcot's foot. I went to a surgeon to see about having surgery, but the surgeon said he wanted to amputate both legs below the knees. I don't want to do this. Okay, first of all, the only reason for amputating legs is if there's such poor circulation that you have an infection that can't possibly heal even after months of intravenous antibiotics, and the infection is spreading up the legs. That doesn't seem to be the case here. I'm alone and worry about mobility issues. Have you treated any patients who had Charcot foot amputations? Do you have any suggestions? I've fortunately not seen a Charcot foot amputation. I have treated people with Charcot feet, and there are special types of shoes that take the pressure off the feet, take the forces off the feet, transfer them to the upper leg, and we try to control their blood sugars. With blood sugar control, sensation returns. These special boots also straighten up the ankle. They frequently have foot drop, and we want to straighten the ankles so they're not tripping over their feet. So there are a lot of things that can be done. I also had some patients who had a combination of Charcot foot plus venous stasis edema, and we used Uniboots to get rid of the edema, and then fitted them with these special boots that kept their feet protected. So there are treatments, and certainly surgery just for Charcot's foot is not the answer. By the way, I have a sign in my office quoting Jean-Martin Charcot, the guy who first discovered Charcot's foot. Let's see if I could find it. Here it is. It says, theories, no matter how pertinent, cannot eradicate the existence of facts. And I keep it there because it's sort of an answer to the American Diabetes Association. My mom is 84, type 2 diabetic for 35 years, 80 pounds overweight, takes low doses of insulin, also takes metformin, levothyroxine. She eats under 30 grams carbo per day. We're in a quandary as to how to titrate her off insulin so she can lose some weight. Well, first of all, what will happen to her blood sugars if you take her off insulin, you really should read the book, because she first has to be on a very low carbohydrate diet. You'll have to lower the insulin at the same time that you lower the carbohydrate. It's really the carbohydrate that's keeping her fat, and it's tricky to both lower the insulin and lower the carbohydrate. But there are formulas in the book that tell you how to estimate how much insulin you need for how much carbohydrate and so on. So I suggest that you read the book carefully. It would be nice if you had a family care doctor who would cooperate with you and prescribe what insulins you need and so on, and help you with the guesstimates that you're going to have to make. There's also the possibility of using metformin, increasing the dose of metformin. She's getting 1,000 milligrams a day. You might want to double the dose, but all this should be with the doctor and with planning, and using the book as a guide. Another thing that you might do is check her free T3. She may need more than just 25 micrograms of levothyroxine, which is T4. She may need timed-release T3, as most hypothyroid patients require, and that facilitates weight loss. So there are probably a number of things that should be done simultaneously. Our 4-year-old has not yet been diagnosed with diabetes. Well, that's good. We see blood glucose levels over 200 several times a month, but his glucose levels are now below 140 the majority of the time. Wow, the majority of the time is not all the time. He just had a 2-hour oral glucose tolerance test done, and his glucose was normal, peak at 60 minutes of 137. His insulin was rather low. Can early diabetes cause low insulin but normal glucose? Yeah, it can, but you just got through saying that he's over 200 several times a month. And with the glucose tolerance test, they usually give 100 grams of glucose. I doubt that he's been eating 100 grams of glucose at one time, any time during this month. That alone would be diagnostic. So I have a feeling that he should probably be treated as an early type 1 diabetic. It would also be interesting to know if there's a family history of diabetes. Also, if he is peeing a lot, losing weight, etc. A 65-year-old man diagnosed with type 2 diabetes in 2008. It's about 11 years ago. After reading your books, I promptly adopted a low-carb diet, lost 70 pounds, and began taking metformin. I'm 6'2" and currently weigh 200 pounds, which I think is about right. My most recent A1C was 5.6. C-peptide was 3.4, where the lab's normal was 1.1 to 4.4. That shocked me. This makes me think that my pancreas is making enough insulin and that my problem is insulin resistance. Well, first of all, if you're not overweight for your height, and it's hard for me to tell, it's not likely to be insulin resistance. But there's one other point. your C-peptide was reported, but not the blood sugar at the time. If you had a blood sugar, here your A1C suggests an average blood sugar of 124 for the 5.6%. And that means average. So you could be going from 80 to 160 or 170, and if you had a high normal C-peptide with a blood sugar of 170, that's not anything astounding. So just looking at the C-peptide without the blood sugar doesn't have very much meaning. And as I said, if you can grab more than, let's say, an inch of skin fold thickness around your waist, you may be insulin resistant. Is that it? Okay. Well, that's it for tonight. Wait a second. That's it for tonight. Our next teleseminar will be on Wednesday, March 27th, 2019. Thanks for listening and watching. We'll be seeing you then.